Bismillahirrahmanirrahim. Today's topic is about the long-acting antipsychotic injections, which were traditionally called depot antipsychotics. So we will make an overview of that today. And my talk is derived from an article of 2015 by Peter Bosnack and David Jonathan Castle, taken from British Journal of Psychiatry Advances. So depot antipsychotics, this is the older term, but now the newer term is used is the LAIs, or long-acting injectables. So author's perception was that they are underused. And about their nomenclature, let's talk about depot or LAI. So depot is the older term, LAI is the newer term. But sometimes we use the older term for the older long-acting injectables and use the newer term for the newer long-acting injectables. So for example, depot, haloperidol for Modicate, or fluphenazine, for example, or flupentixol, suclopentixol, they can still be called, and haloperidol, they can be called depot. And while the other newer injectables are called LAI. So the older depots were mostly oil-based, and the newer depots are water-based. So that's the difference. So one way or the other, the better term is LAIs for everyone and for everything. LAIs have a better place at various stages in the continuation of care, and they should be one of the options discussed with any patient requiring long-term treatment, even early in the illness course. So that's what the authors suggest here, that even early in the course, they can be considered. And declaration of interest. So the authors have received grants from Eli Lilly, AstraZeneca, Janssen, and other companies. Challenges. So what are the challenges of giving the LAIs or depots? So first of all, extrapyramidal symptoms can occur, akathisia, tardive dyskinesia. Well, the acute symptoms can be managed by giving the test dose, and hence you know something is happening or not, or by giving the oral uh, medication, oral alternatives. But if we go with the uh, uh, injectable alternatives, so and then or continue something for a longer time, then what could happen is tardive dyskinesia. And this can happen to any medication, any LAI, or any oral even. And even aripiprazole, I've seen cases with tardive dyskinesia on aripiprazole. Metabolic side effects, yes, as with other things, the depot injections can also cause metabolic side effects. Hyperprolactinemia can be another thing. Sedation, breakthrough psychotic symptoms. We see very often that when the depot is wearing off and one dose is wearing off, and before the next dose, there can be some breakthrough symptoms. Local side effects. So locally can cause, for example, like the cellulitis or bruising, things like that. Stigma. Another thing is many patients don't want to get depots, and when they do get, if they have to tell anybody, they feel that it's very stigmatizing for them. Cost effectiveness. So that's another thing. Sometimes it is they are like very expensive and difficult to meet the expenses of the depots. So all these are the challenges. Then patient's consent and willingness to accept the long-acting injection, staff availability and capacity, and so staff, are they available to give and administer the depot antipsychotic or not? Antipsychotic polypharmacy is more likely in patients treated with LAIs and in those with suboptimal response to a single LAI. So if you're giving long-acting injection and you get the maximum dose and it's not working, then you might have to add something else, and that will lead to polypharmacy. Now, then the indications. So indications of depots, mainly it is schizophrenia, first episode psychosis, schizophrenia, and comorbid substance misuse. But unofficially, not mentioned in this article, unofficially they are used in other things as well. So sometimes staff are not available to administer, and then we're talking about the antipsychotic polypharmacy is more likely. So, and then the response wearing off is another thing. And what we are saying is that the indications, sometimes we can use it for very difficult cases of bipolar affective disorder, and also for borderline personality disorders with huge behavioral problems. But these are basically unlicensed uses. So the licensed is the psychotic conditions. So if we compare the LAIs and orals, so steady levels. So LAI give you steady levels, and also they ensure compliance. If the patient is coming for the depot once in 3 weeks, once a month, once a week, once in 2 weeks, once in 3 months for some depots, at least that shows that the drug is going to stay in the system and will have steady levels. So, and then we come to the first and second generation LAIs. So first generation, we said that they were fluphenazine, flupentixol, zuclopentixol, haloperidol. And then the second generation are aripiprazole, paliperidone, risperidone, etc., even olanzapine. Acceptability of LAIs. So common goals. So we discuss with the patient that this is the rationale, and these are our common goals. We want you to work towards your betterment and well-being. Then psychoeducation. So psychoeducation we need to do, and recovery approach, that this is something going towards the recovery. And then there are biopsychosocial benefits, and involve the patient as much as possible in the discussion if they are going for LAIs, and also take their previous experience on LAIs into account. It is very important. If somebody had an adverse reaction on zuclopentixol, don't go with the zuclopentixol again and possibly avoid flupentixol as well. And then haloperidol may be a good option in those cases. So if somebody got akathisia on aripiprazole, then avoid aripiprazole in future. So side effects is another thing. And the compulsory administration of LAIs under the mental health legislation, because the patient is at risk of harming themselves or others, does not mitigate the onus on the clinician to take a recovery-based approach. So even we can, as clinicians, we can compulsorily give the depot medications to the patients, but we have to take the full recovery-based option into account, recovery-based approach into account. And it's not good for their recovery if they are coerced into the depot. So try to avoid the coercion in this case, and try that they are involved in the decision making as much as possible. And when you're giving the depot, you're involving them as well. So that should be our aim. So that doesn't mean that they are giving the full consent, but at least they are agreeing, even half-heartedly. And patients who perceive coercion in their contact with the mental health services are less likely to be engaged in care. So those you will lose the patient after some time if you are coercing them for the depot injection. And it was also seen that two-thirds of patients were not given sufficient information by their clinician. So give information to your patients when you're starting with the depots. Fear of losing autonomy and control. That's another thing you have to address. If the patient is uh, saying that they don't want to be on depot, listen to them and tell them that yes, they are autonomous, they are free to decide, and they can stop their medication whenever they want. They have the autonomy and they have the control. So this is our advice, that it continues for a longer period, but still they have the autonomy. So at least they start and then they decide after a couple of months whether they want to control or not. And they will be fully in charge with that. So clinicians often view LAIs as a last resort. So, and that is debatable. Sometimes people think that LAIs are last resort. Some people jump on them early. Same with clozapine. Some clinicians jump on clozapine quite early. Some wait for some time. And both things have their pros and cons. Noise guidelines. So, not to offer the antipsychotic medication to at-risk mental state. And my take was that sometimes we have to give the oral, especially the oral antipsychotics, to at-risk mental state as well. Exceptions are there because if there is a risk, if the risk is very high and very, you're almost sure that the patient is heading towards psychosis, then start something to avoid the risk, whether it's antidepressant or antipsychotic. Then waist circumference, pulse, blood pressure, ECG, and especially ECG for the inpatients. And then, so all these things should be recorded periodically. Fasting blood glucose, HbA1c, lipids, prolactin should be monitored, and assess and monitor for any movement disorders, nutritional status, diet, activity, and so activity monitoring, and offer them the referral to the nutritionist or dietitian, monitor for symptoms and side effects, and psychological interventions should be there alongside the antipsychotics, family intervention, and CBT for psychosis. These are the two interventions that must be considered alongside the antipsychotics. The choice of antipsychotic to be decided between the person and clinician, taking into account the views of the patient and carer. So go along with the person and their carers. And so provide information for each drug. So even if you are starting them on a depot, give them the options of 2 or 3 drugs and provide information for each drug and let them decide. Start low and go slow. So lowest possible dose and increase the doses very slowly. And do not use a loading dose medication. Exceptions may apply, but only after trying oral equivalent at lowest effective doses. Then do not initiate regular combined antipsychotics except for short periods of time. And then offer clozapine to non-responders to 2 medications. And augmentation can also be an option after clozapine hasn't worked. So nice guidelines on depot and LAIs continue. Consider the long-acting injection for people, number one, who prefer this treatment after an acute episode. So you can start even after an acute episode as long as the patient is preferring that. And then, or we're avoiding the uh, covert non-adherence. So where there is non-adherence, that whether it's unintentional or intentional, you want to avoid that. You don't want to take chance, then give them depot. And initially use a small test dose as set out in BNF or SPC. But of course, there can be loading doses of paliperidone or aripiprazole even. So what, like in the 2 injection start. So but even that before that loading dose, it is very important to test the suitability with the oral equivalent. And if orally they are tolerating, then go for injectables, even for paliperidone or aripiprazole. Although you're not giving test dose, but still you're giving oral equivalent and then the loading dose and then the regular dose for paliperidone. And LAI preparations and doses. So haloperidol starts with 50 milligrams every 4 weeks, goes up to 300 milligrams every 4 weeks. Flufenazine, 12.5 to 100 milligrams every 2 to 5 weeks. Flupentixol, again, 50 milligrams every 2 weeks to 300 milligrams every 4 weeks. Zuclopentixol, 200 milligrams to 500 milligrams every 1 to 4 weeks, but you can go up to 600 milligrams per week in some cases. Risperidone, not now used much, risperidone consta, because it's only 2 weeks, and we have better alternatives in form of paliperidone, which is monthly, but it was 25 to 50 milligrams every 2 weeks. And then with the risperidone injection, you wanted the orals to continue for a long time. Then olanzapine, so 150 to 300 milligrams every 2 weeks, or 300 to 405 milligrams every 4 weeks. But for olanzapine, you have to check for the post-injection syndrome after each injection. So the patient has to be monitored in the outpatients department for about 2 to 3 hours. Paliperidone, 25 milligrams monthly to 150 milligrams monthly. So normally we give 100 milligrams monthly as a default. Aripiprazole 400 milligrams monthly. And both these medications, it is important to give oral equivalent mm, before starting the depot and at least for another 2 to 3 weeks. And first generation LAIs, so haloperidol, fluphenazine, flupentixol, zuclopentixol, and pipotiazine. So pipotiazine was used in the UK, but now for the last about 8 years, it has been discontinued, and there were patients who were quite stable on that. Uh, may take 2 to 3 months to reach the steady state plasma levels. And fluphenazine and haloperidol have higher rates of extrapyramidal symptoms such as tardive dyskinesia, dystonias, Parkinsonism compared to other medications. And then some first generation are mainly oil based. So what oils are used generally? It's either sesame oil or vegetable oil. Second generation are olanzapine, risperidone, paliperidone, aripiprazole. So risperidone is delivered via microspheres and orals for long periods of time, maximum fortnightly, and it has to be refrigerated. While paliperidone is aqueous suspension, it comes as an aqueous suspension of paliperidone palmitate, and olanzapine. So that's the 9-hydroxyrisperidone is paliperidone, and olanzapine palmoate via nanoparticles, and refrigeration is not necessary for these two medications. So that's an edge against the risperidone consta. Then, then the freeze-dried powder is reconstituted in sterile water for aripiprazole monohydrate. So it is freeze-dried powder, and then it is used for injection later on, reconstituted. Olanzapine post-injection syndrome. So what happens is sometimes the injection is rapidly absorbed and it can lead to especially the anticholinergic side effects. So that means increased heart rate, tachycardia, confusion, etc. So to avoid that, it is recommended that keep the patient into the outpatients for another 3 hours, and later on could be reduced to 1 hour after a few months when you know that the patient doesn't develop post-injection syndrome generally. But initially, it should be at least 3 hours. So continue oral for 2 to 3 weeks, most second generation LAIs, even after starting the injection. Recent advance, 2 injection start of aripiprazole. So what happens is that instead of giving orals for another 2 to 3 weeks, what you can do is you can give 800 milligrams of aripiprazole, but 400 milligrams on one arm and 400 milligrams on the other arm, and then you don't need the oral supplement. All you need is maybe one oral dose as well, just a single stat oral dose, and that's it. And then the second dose, the subsequent doses will be monthly, and it will be 400 milligrams monthly, not 800 milligrams. So only the first dose is 800 milligrams, and not in one go, but it is on two different arms. 400 on one arm, 400 on other arm, and then the oral equivalent is not needed. Post-injection syndrome. So as we discussed that it happens with olanzapine, and it involves sedation, delirium or altered conscious state, speech and gait disturbance, And sometimes if it gets severe, it can lead person to go into the ICU, and there have been reported deaths as well due to cardiac arrhythmias or cardiopulmonary arrest. So patient must be monitored for 2 to 3 hours after each injection, especially for the first few months. LAIs in clinical practice. So the authors of that article, which I'm quoting, is they feel that they are underutilized for schizophrenia, including the first episode, and also for schizophrenia along with substance misuse. So they are underutilized. And the author said that, or they felt that it should be utilized more. So patient, clinician, and service barriers are there. Patients prescribed LAIs may relapse even when adherent to LAIs, and that can lead to polypharmacy sometimes. And it may experience significant side effects. And consequently, continued LAIs may not be appropriate for all patients, even if oral adherence was not that good. And finally, there is a Liverpool University neuroleptic side effect rating scale, Lancers 1995, and it uh, tells you about the rash, difficulty staying awake during the day, runny nose, increased dreaming, headache, dry mouth, swollen or tender chest, chilblains, difficulty in concentration, constipation, hair loss, urine darker than usual, period problems, tension, dizziness, feeling sick, increased sex drive, tiredness, muscle stiffness, palpitations, difficulty in remembering things, losing weight, lack of emotions, difficulty in achieving climax, and weak fingernails. So these side effects have to be taken into account. And then there is also another scale, GASS, Glasgow Antipsychotic Side Effect Scale. So these are all the it's all about my presentation on the depot antipsychotics. And thank you very much. Until the next time.